morning, everyone. My name is Cassandra Noor, and it brings me immense joy to welcome all of you to our second of 4 sessions in our education series. We're very excited about this education series we've designed and developed based on your feedback. So at this time, we'd like to recognize and thank our donors, Barb Tillender and an anonymous donor, for their kindness and generosity in helping making this education series possible. I'd also like to thank my colleagues, Marie Martinez and Elena, and from the Memory Clinic, and members of Dr. Tartaglia's research lab, who've all been instrumental in making these sessions possible. Just a few housekeeping before we begin. When you registered outside at the table, you received a care package which has your registrant ID and surveys. We've asked, if you haven't already, to finish up completing the first survey, and there's another one in yellow in your folders to complete after as well. We strongly encourage you to complete them, as we do appreciate your feedback. And so we'll come around to collect those after. I see you guys already helped yourself to the coffee and snacks, which is great. At the end of the talk, we'll have plenty of time for question and answer periods, so please save your questions till the end. If you have any other questions, we're all here around, so feel free to ask. And that's all, so I'll leave it to Elena to introduce our keynote speaker.
Thank you. Okay. Her name is Dr. Andrea Aya Boney. She's... Okay, I can speak louder. Can you hear me? Okay. Okay, Dr. Aya Boney is a researcher and geriatric psychiatrist. She is an assistant professor in the Department of Psychiatry at the University of Toronto. She is based at the Toronto Rehabilitation Institute, University Health Network, where she is research lead in the Geriatric Rehabilitation Program. Her clinical work is mostly focused on the care of people with dementia. She works on a dementia behavioral inpatient unit at Toronto Rehab. She also visits nursing homes in Toronto, does telepsychiatry consultation to Northern Ontario, and sees patients in memory clinics. Her research examines the use of technology in supporting people with dementia and the intersection between psychiatric symptoms, their treatment, and mobility in people with dementia. So I'd like to welcome Dr. Andrea Aya Boney.
Thank you very much for inviting me to come speak today, and thank you all caregivers for being here. I know that your time is really precious, that you have a lot of demands on you, and so I'm going to try my best today to respect that and honor your time and make this as useful for you as possible. And so I'm actually going to ask that people feel free to ask questions as we go along. I'm happy to make this interactive. I kind of see this as a workshop, and as a workshop I want to be able to, you know, change direction and address your specific concerns. I'm not a mind reader, so I'm not 100% sure what it is you guys would find the most useful for this. So I do encourage you to contribute. And in that vein, that's why I've put up this poll. And so I don't know if any of you have had a chance to navigate to this page. But if you have a phone or a laptop or something, I'll leave it up for another couple of minutes. And even for people who are watching on the live stream, you can do this from anywhere in the world. So if you have a moment, log in and do the survey, and then that will help us, you know, a little bit too in guiding where we're going. While we're waiting for people to fill their survey, I wanted to start today with a little anecdote that illustrates something. An idea? That's better. Okay. So I need to stay close to the microphone. Okay. But you can hear me okay. This is good. Okay. An idea about one of the reasons why people with dementia might have a change in their behavior, something that may at first seem unexplained or unexpected. And this story actually relates to me and my daughter, and it happened yesterday. And so I'll describe the scenario. But before I start, who here has heard about attachment, the idea of attachment? So I'll start off by talking a little bit. So attachment is this idea that we have important relationships in our lives and that we have an attachment to those people. And when we feel that that attachment is threatened in some way, then it sets off a whole cascade of really intense emotions in the person. And it could be a lot of different, everyone responds a little bit differently when their attachments are threatened. So the example is that last night I was trying to get my daughter to go to sleep, and because I really wanted to come and work on my slides for today. I really, really wanted her to sleep. I think maybe I was a little bit tense, a little bit impatient with her, and she picked up on this, right? She sensed that I was a little bit tense and a little impatient with her. And this set off, I think, a little bit of attachment panic in her. Like, why is mommy acting? Like, why is she upset with me? I don't know what she was in her mind, but I know what happened, which is that she wouldn't go to bed. At first, she was, silly and trying to get me to, and then I got a little more irritable with her, and now she's starting to say, "Mommy, I really need to cuddle you." She's getting anxious and she's upset, and then I'm like, "You get into that bed," and at that point, it's like, whoo, full blown, really angry with me, will not stay in her room, will not stay in it, and I'm getting, I really have to work on my presentation now, and so now we're in this kind of a little bit of a crisis because she's having a tantrum, and I'm really frustrated with her, and that's okay. What's happening here? And so that's when I realized that I had sort of set off this cascade indirectly, unintentionally, because I was a little bit occupied in my own mind with what was going on. And so I worked a little bit to cuddle her, to reassure her, to, talk, and, I gave her a little bit of an insight into what was going on in my mind, helping her to understand that it wasn't that I was upset with her. I was thinking about something else. And we had a little moment, and then she calmed down and went to sleep. And so that's an example of one way in which attachment can get threatened, and that how it can set off a kind of reaction that in the moment seems like, what is going on here? Why won't you go to sleep? Was it that you have too much sugar today? You can think of all kinds of reasons outside of the relationship, but often there is a reason within the relationship. And the other reason I give this example is because it illustrates that, nobody is perfect. I'm not a perfect mother. No caregiver is a perfect, that actually life is full of these little ruptures in attachment. It's just normal, right? That we are good and then we're not good, and then we repair it, and then we're not good and then we repair it, and this is completely the way things are. And so I wanted to, just because I know that at these sessions that sometimes people present stories, and I want people to feel reassured that they're not going to be judged, that I hope you're not judging my parenting too much now. And so this is just the way things are in life. We have little disagreements and problems, and we perceive threat in our relationships, we get anxious, and then we fix it. So I'm going to move on quickly to look at your answers to the poll. I want to know where we're going in this talk, so I'm going to turn this over here. So to get the answers to the polls, I got to leave my presentation and go in. Wait, great, 10 surveys, 6 surveys underway. We'll start looking at the results, and those people who are filling them in, you can keep going. All right, so we have a big range in terms of experience, in terms of caregiving. So it kind of splits a third, and a third along in this group. And then let's look. Just want sort of a side question. Are there any people with dementia who are here today? Who don't mind? Mostly caregivers today? Okay. Yeah, well, yeah, who knows? Yes, and then, fair enough. And people who are caregiving for someone that they live with? Yeah. For someone who lives on their own but in the community? And someone who lives in a nursing home or other kind of residential setting? Okay, great. Just wanted to get that sort of profile. Wow, okay, we've got a beautiful word cloud. Thank you, guys. So interesting, dangerous is the word that, so this is, so people are worried about dangerous kinds of behaviors, risky behaviors. So that's something we can certainly touch on and talk about behaviors that are dangerous and how we might approach them. Concerns about people's judgment. I'm not sure what backlash. And what do we have? We have something, any other words that jump out there? Words that describe changes that concern you the most? Oppositional, forgetfulness, childishness, doesn't understand, delusions. Okay, so these are some of the, so definitely get the feedback that you guys want to touch on risky behaviors. And so like a fewer range of words, but sad, that's a really, so how do you deal with the feelings of loss that relate to sort of how people are changing, the person that you're caring for? Feelings of feeling responsible, feeling like a failure, feeling worn out, fatigued, tired, feeling useless, like that like this is kind of out of your control and what. So those are all very common sort of feelings that people, caregivers might have when confronted with someone who's got changes in their behavior. So we'll certainly kind of talk on some of those. Okay, so we've only got one person who put in an answer in. Oh, they're coming up slowly. Strategies to manage. Okay, so strategies are something we'll talk about, ways of finding support. I'm just gonna let that keep coming up. Ooh, it went away. Okay, there it is, knowledge. It's coming up slowly. Okay, so this is a good starting place. So I started off by telling you a story that is about a psychological reason why somebody might exhibit a change in their behavior. And I kind of see that their changes in behavior and dementia are related in part to psychological changes, so changes in terms of relationships and ways of people have of coping with their symptoms and their environment and such. And then there's a real biological component to it as well. There's actual changes in the brain that lead to symptoms that mean that people are more prone to have changes in their behavior. And so understanding the meaning, okay, a cure, yeah, I'll work on that too. Yeah, okay. So now as we go along, you're also welcome to write down questions. You've got a little pad there, and as I said, feel free to shout them out as we go. So getting into a presentation. So I'm gonna try to, I don't want to just kind of rigidly follow the PowerPoint presentation. So if I say something that brings up a question, yeah, please do ask. Okay. I just put this up just to explain that I don't actually take money from any drug companies or anything like that. So I'm hopefully a little unsullied in that way. So, so I'm going to try to touch on the factors that contribute to changes in behavior and some approaches to understanding. And I'm going to present some different approaches. You know, not any single approach is going to work for everybody. And to consider treatment. Now, no one mentioned medications, and so one of the things that the organizers asked me to do was to bring some information about medications. But is there an interest in talking about medications or focusing more on strategies outside of medications? Including the talk about medications. Okay, so I will go to there as well. Okay, so this slide, I think it's just meant to describe that there are lots of changes in people with dementia, that it affects a lot of different areas. And so we think often about memory. Everyone knows about the effects on memory. It's sometimes easier to forget that it affects people's ability to execute motor skills. You know, they might get more clumsy with their hands, or, you know, that it affects things like there's what we call social cognition, like so their ability to judge social situations. That's like someone who's you know, they might blurt something out inappropriately, or you know, get really anxious when they're around people because they've lost that ability to judge the appropriate behavior in that scenario. And then there's this, like in purple here, I have this little ball, which is the neuropsychiatric symptoms. And I think this is an area that not a lot of people think about, and that's why I want to touch on this, that there's an actual biological contribution to changes in behavior in people. So this is, you know, relates to the ways that the changes in the brain that happen over time. I don't mean to overwhelm you with this, but I just mostly put this here as a reminder for me to talk about these things. So I think the way I think about it is that these neuropsychiatric symptoms fall into these sort of different categories in relation to what part of the brain is affected. So there's this thing called the Salience Network. It's a kind of fancy word, but really what it means, it's the part of the brain that tells you what's important to pay attention to. So an example might be somebody who becomes really stuck on like a cushion being in the wrong place, and then they're so focused on this cushion that they start to jumping to conclusions. The cushion's over there, and that means that, you know, your sister was here and that she stole something, you know, like, so that cushion becomes sort of the center of everything. And so normally in our minds, we know what to pay attention to. We don't get focused on one thing so fixedly. But the Salience Network can be affected, and so people with dementia have trouble knowing what's important to pay attention to and what isn't. And so this, and also sometimes what is real and what is not. And so changes in the Salience Network is what leads to symptoms like psychosis. So that's delusions, these fixed ideas that are not true, belief in something that's not real. And some of the obsessive symptoms that we see too. And so then there's the cognitive control region. And so that our cognitive control is the really important part of our brain that helps us regulate our mood, right? Because it's the part of the brain that tells us, yeah, that was really frustrating, but that's okay. Pick yourself up. It's not. It's the part of our brain that helps us to shift our attention away from things that are stressful. Helps us to put things into perspective. I got a bad mark on that test, but it doesn't mean that I'm a failure. It just means that I didn't study enough, and the part that reasons us through these kinds of things. So people with depression, for example, have problems with their cognitive control. They get really stuck in negative loops. So it's a part of the brain that lets you let things go, helps you make decisions, and helps you control emotions. And so that's a part of the brain that's also affected in dementia. And so they struggle in all of those areas sometimes. And then the last part is the response inhibition part of the brain. And so this is the part of the brain that says, no, don't go there. No, don't do that. It's the part of the brain that helps you appraise risk. That's not such a good idea. Let's not climb on the table. Let's not, tip over the couch. That's not, that's dangerous, or that's going to hurt someone's feelings. So it tells you when to act and when to stop. And it also helps you appraise threats in the environment. So, that guy on the subway, he's looking at me funny, but I'm safe here. But for somebody who has trouble appraising the intensity of the threat, they might think, okay, that guy's looking at me, I'm in trouble. You might leap to some conclusions and might react more quickly than someone who can't appraise threats. So that's the response inhibition part of the brain. So you can see that if you have someone who's having changes in their brain that in some of these areas, how they may have difficulty responding as someone without dementia would in different circumstances. So there's a real biological reason why behaviors come up. So I kind of touched on these different sort of spheres when I was talking about that, but this is how I break down this kinds of main neuropsychiatric symptoms of dementia. So I think about psychosis, so delusions, hallucinations. So that's the problem with the Salience Network. Can't tell what's real, what's not. Can't really tell what's important to pay attention to. Is that people have seen delusions and hallucinations? I want to make sure that I draw like a distinction. So delusions are usually there's some story behind them. So it's like someone is stealing from me or someone is poisoning me, and there's a little bit of. Some people sometimes think that if someone says, "Oh, I'm 15 years old and I'm back in my home country," that's a delusion, and I don't necessarily consider that a delusion. That's really someone being a bit disoriented and with regards to time and place, right? So they may have a fixed idea that's not true, but it's not quite the sort of system of beliefs that we think about in terms of a delusion, or not the paranoia that we would see in a delusion. Okay. Any questions about that? About what's a delusion, what's not a delusion, what's a hallucination, what's not a hallucination? Okay, great. So then we think about changes in terms of affect. So that's another word for emotion. So that's depression, anxiety, irritability. And very rarely you might see someone with the opposite, where they have elevated mood, where they might be manic. So that's down to the sort of the control network of the brain, and they end up with these symptoms that means that their moods are off. Then there's this change in activity or drive, and so this is where I put the normal regulation of when we sleep and when we wake, and when all of that can get thrown off. Hey, I got 10,000 steps. Sorry. Maybe I'm waving my arms a lot. I think that might be it. So this is apathy. So not a lot of drive to move, to do things, a lot of inertia. So losing their usual kind of get up and go. Problems, or the opposite, hyperactivity, right? So they actually have too much drive and they can't sit still. And then we've got people with the problems in their sleep-wake cycles, sleep disturbances. And then the last circle is loss of inhibition. So this would be a little bit of what I was talking about earlier, people who have something off in terms of their ability to appraise risk or threat. And so that can sometimes lead to aggressive behaviors. They may think that someone is trying to hurt them, and not fully grasp that the threat is quite low. And it leads to problems in terms of their social judgment, undressing and those kinds of behaviors. So I present this because it just sort of shows how frequent or common these different kinds of behaviors and these different categories are. But I'm going to change the slide. And the reason is that there's a problem with this slide in that the way that it's scaled only goes up to 40. And it makes it look like everybody with dementia gets these behaviors. If you scale it up to 100, you can actually see that these behaviors are not super, super prevalent. They are out there and they're a problem, but not everybody with dementia will develop these problems. So that I mean that as reassuring, because I think that it's easy to come to these talks and leave with a kind of hopeless feeling that everything bad is going to happen. But that throughout the course of someone's dementia, they may exhibit one or two of these behaviors at different times, but the majority of people with dementia will not experience all of these symptoms all the time. So that's a reassuring thing. And so things like agitation or aggression, the more sort of severe symptoms, we're probably talking like 10 to 20% of people with dementia will at some point have a period where they are exhibiting these symptoms. So this is a way I use to think about the relationship between the biology and the psychology. So on the top, we have those biological changes that I was mentioning earlier that can happen in dementia. So the symptoms that develop because of changes in these different networks. So the psychosis, the changes in drive, affect, and loss of inhibition. And then I have across the bottom some of these other sort of factors that we know are really important. So we're talking about personal factors. So it could be that you have someone who had a history of trauma in their life and are very prone to becoming anxious or overwhelmed in senses when they feel out of control or powerless or under threat. And so their reactions are really informed by this history that they had and who they are and these experiences they've had over their lives. Other personal factors have to do with someone's, physical well-being. They may have a lot of pain or a lot of physical symptoms of whatever kind, and that this puts them in the context of not feeling well. And if you don't feel well, you're more likely to, if you think about what you do when you don't feel. I had a cold over the holidays, and I was like a terrible grumpy person. I just had a sniffle. It's hard to be yourself when you're not well. So that's another sort of personal, individual sort of factor. And so I think about the personal as reflecting in some way someone having unmet needs, whether they're psychological, so whether it's like attachment needs, like their need for interaction, need for a feeling of belonging, need, that you could come up with a whole bunch of kinds of needs that people with dementia might have. And so in some way, those needs are not being met. And so that puts them at risk of having some of these behavioral symptoms or changes in the context of the biological changes. So then we come to the social factors. And so that relates to, who's around them. And so this is where we come to caregivers, but, formal caregivers, informal caregivers, family, friends, neighbors, all of which form the social environment for the person with dementia. And the reason that this is important is that behaviors often happen in the context of social interactions. Like if someone is angry at you, it's not that the person with dementia is just angry, it's that they're angry with someone, right? So there are two people in that scenario. And so a lot of what we're doing when we're trying to support the second person in supporting the person with dementia is helping them to think about where they fit in this interaction and how they can help, how they can adjust to what the person with dementia needs in that moment. And so the reason I bring it up here is that I think about ways in which we unintentionally reinforce people's behaviors. And so, because people are so sensitive to their social environment. So I reinforced my daughter's behavior by not responding in the way that she needed from me in that moment. So she's just got worse and worse you talk about reinforcing bad habits, or it's all part of the same sort of idea in terms of behavioral theory. I'm trying to think of a good example for you about ways in which we reinforce behaviors. There's a common challenging behavior is repetitive vocalizing, and so there was a gentleman that we were seeing who would call out very loudly, very frequently, and so if he was calling out quietly, he would be ignored, and as soon as he let out a real loud one, people would run over and say, "Be quiet," and then leave him. And so that was all of the social interaction that this man had during the day, was getting people coming to tell him to shut up. And if that's all you're going to get, then you'll take it, right? So he unintentionally, the staff were negatively or positively reinforcing the negative behavior. So they were reinforcing it by giving him attention in this way and only in this time. And so the strategy to deal with that is to start working on positively reinforcing the positive behavior, the behavior you'd like him to exhibit. And so that might be, if he is calling out more quietly, if he's then giving positive attention during those times, and finding a way to respond at the times where he yells that is not reinforcing. We don't do negative reinforcement anymore. We don't like give electric shocks and things. That's not acceptable. But the idea is you positively reinforce the positive behavior and you don't reinforce the negative behavior. So that's the idea of the social. Yeah, sure.
So how do you manage, like from that social thing, like so somebody get diagnosed with dementia, and you may need to move them to a facility that is more secure, then you're changing their social environment.
Yeah.
So how do you, what is the best way? Is it still to discuss with them and reassure them it's the right thing, or?
Yeah. So the question, just to repeat it, because I'm not sure they would know is that what do you do when someone's social environment has changed? Like, say they've moved into a new environment, like a residential facility or something like that. I mean, those transitions are always really difficult. So there's a certain. So you try to maintain as much stability as you can in their social environment. You try to find ways to bring to them some of the social environment that they had in the community. You know, encourage people to visit, if possible, take them out for visits and for, and then you work to help create a new social environment for them. You know, as and one in which you really, they feel like they're respected and understood. So I always say to people who are moving into facilities to make sure you put a lot of personal effects around, right? That not only for the person, but they're for people around them to see that this is who this person is and was. You know, I see the picture of their family. There's information on the wall about the awards that they won or the jobs that they did, and then it creates a better social environment for them in their new setting. I think those are some things that I try to do. And then, so the last thing is the actual physical environment. And of course, so the physical environment has a huge bearing in the way that symptoms are expressed, right? So if you have somebody who wanders a lot, and you have a setting where it gives them enough space to be able to wander in a safe way, but it's secure, like they're not getting out and they're not getting lost, that's a big difference than if you live in like a 300 square foot bachelor apartment and, the door is right there and, they know how to open the locks. And so you've got the huge variability in terms of the safety of the environment, the suitability of the environment, and the structure of the environment to support the behavior that the person is exhibiting, right? Because the behavior is the same in both cases. The person is wandering, and in one case it's okay, it's manageable. In the other case, it's really risky and upsetting and dangerous, and it's just the environment that's different between these two scenarios. So those are sort of a kind of overall way of thinking about different behavior changes. So what is it about the person, what is it about their social environment, their physical environment that is making this behavior so problematic at this moment? And so I guess the other thing about behavior is that, like I said, you could have two people exhibiting the same behavior, and in one scenario it's problematic, and the other person it's not. And why is that? It's in part a little bit about how we appraise the behavior. This I have patients who spit sometimes, and so some families, they accommodate it. They put out buckets. They clean it up off the floor when it happens. They're disgusted by it, but could be worse is the kind of approach they take. And then some other caregivers just find that really disgusting. And they can hear them working, and oh my God, he's spitting again. And so much of what is of the behavior is in part in the interpretation and how much it sets us off, right? It pushes our buttons. So that's something to be aware of. What is it about this behavior that is so difficult? And so obviously there are some behaviors that are risky, just objectively risky, and but there are other behaviors that people find ways of accommodating in different ways. So these are kind of a big list of different kinds of behaviors that people can sometimes, and again, not all of these are very common, but I think sometimes people find it comforting, like if they find a behavior on this list, then it's like, oh yeah, it's not me, it's not them, it's something that happens. It's not, necessarily, it's not totally unheard of that people do this. Sorry. So talking about risk. I'm going to come to it again. It just came to mind right now just because we were talking about how we appraise behaviors. I want to touch on the idea of how we manage risk or deal with risk. Because risk is also subjective in some ways, right? I mean, you could have people with dementia often become unsteady. They lose their balance more often, they fall. For some caregivers, that risk is really uncomfortable, really intolerable, right? They don't want them to fall. They don't want them to hurt themselves. I'm not saying that anybody wants them to hurt them, but it makes them really anxious that the person that they're caring for might fall. And then other caregivers are able to understand that to some extent that we do whatever we can to prevent falls, but falls will probably still happen, and are able to be a little more relaxed about it. And so that's an example of about appraising the risk, about deciding about how much risk you feel comfortable accepting. So this applies to other kinds of behaviors. I just used falls as an example because it's kind of convenient. So wandering is another example of how much risk you are willing to accept. And so I sometimes have people say, you have to help me give the person I'm caring for medications to stop them from doing this behavior because I'm really scared they're gonna wander away. And I worry too. I don't obviously want my patients to wander away. And so it's but is a medication going to help? And you end up with a big discussion. I had a family who had a loved one who wandered. And it was such a big part of his life, walking, and he would go out and, he'd be gone for a few hours. They had a GPS on him, and they'd look him up. They're like, oh, here he is. And they go and they pick him up and bring him home. I don't know, oh my God. And they said, listen, this is what we have to do because this is so important for him. He's been doing this his whole life. He goes out to he's crossing the street fine. He's not climbing into strangers' cars. He's just visiting the barber shop and the coffee shop and the community center. And, he's, just moving around and enjoying the freedom of being able to move around his environment. And I'm like, okay, if you think that's okay, we'll go with that. And he enjoyed 2 wonderful years at home with it. Everyone in the neighborhood knew him. He was, and I'm every day, I'm like, is it okay? Has everything been all right? They're like, yeah, we find him, we bring him home. And then one day he was found on the Don Valley Parkway. And that sort of crossed a limit, right? And he was safe, he didn't get hurt, he was picked up by the police and brought home. But at that point they tried to stop him from leaving, and that of course made him upset, angry, agitated. They couldn't contain it, and it set off a whole cascade that led to him end up moving into long-term care, and he died within 3 months. And so you can see how, so it's about us managing our anxiety, managing the risk as best as we can, and then kind of going from there. And it's a lot of making stuff up as you go along, and it's, but let's think about, we have to think about, so everything is not automatically, we don't say this is like a deal breaker, this behavior is so risky that, but there are a few exceptions, and so I'm just going to touch on a few things. I want to also talk about the difference between these two ideas, and it's something that I think is important to think about. And so the first is, so if you have someone who is pushing away or hitting and being physically aggressive in some way, there are two different kinds of aggressive behaviors in that context. And the first category I think about is behaviors that are where someone is resisting something that you are trying to do to them. Right? So you are in some way imposing upon them. I mean, it's very reasonable. You want them to have a bath. You want them to change their clothes. You want them to shave. You want them to eat. It's something that, but they are feeling imposed upon. And so they push back. They're saying, no, get away, stop. And so that's one category of a kind of aggressive behavior. And I think about that quite differently from the second category, aggressive behavior, which is more offensive, where you're not imposing on them in any way, but they have this filter is lost, this response inhibition in some way is lost, their appraisal of the risk and the threat in their environment is off, and they feel frightened or scared or paranoid, and they lash out in some way. And so that's a different kind of aggression. And so the first kind of aggression is very common, and there are often ways to work with that. And the second kind is rare, but is a more riskier type of behavior, and the type of behavior that I can talk a little bit later about how we manage that. So I just want to, does anyone have any questions about that and that distinction?
On the resistance side, so how do you get them, so let's say they don't want to have a bath.
Yeah.
What is the best way to get around it and give them a bath?
Yeah, that's all. I mean, that's a whole talk in and of itself, how to get people. So I might not go into specific strategies right now, but there are a lot of resources, I think, for caregivers in finding different ways of approaching that. A lot of them are about, and I know they're not always effective, right? It's about, setting routine, giving the person as much control as possible in the situation, finding ways to address any sort of comfort issues or dignity issues that are arising out of the provision of care, and sometimes it's about being persistent and just today's not the day, maybe tomorrow will be the day, and until you get to the point where there's a real risk issue like skin breakdown or other kinds of problems. But people with dementia maybe don't need to have a bath it's about adjusting expectations in terms of what is needed, and anyway, so that's a kind of a beginning answer to that. But so some of the resources you have, I think, are good, and I'll talk a little bit about some of the resources later as well. Okay, so the essence of what I'm talking about here is that a lot of what we need to do in approaching a behavior is try to get at that, like what that need is in some way. And that's hard because you have to kind of step outside of yourself in a way and try to get a little bit into their world and try to understand what it is that they're trying to communicate. And I think it has to be a really specific need that you have to try to work your way towards. Because sometimes people say, oh, they're just trying to get attention. And I think trying to get attention is like the higher, but it's not granular enough. Like, why are they trying to get attention? What is it that makes them want to have attention in this moment? And so that's not a satisfying answer typically, right? People don't do things just to get attention. They do to get attention because they're feeling this, or because they're afraid of something else, or So. Here's an example of like the because, right? So someone is being really repetitive, like you've heard the same question for the 50th time in the last hour. And so are they trying to get attention? What are they communicating in that moment? And so I might think, what is it about, why are they feeling anxious? What's making them feel uncomfortable about the situation right now? And they're sort of trying to communicate, I really feel off, so what's happening next? I don't, you've told me that we're going to the appointment, but that's making me really nervous, and so I'm asking you over and over again, when are we leaving? And so they're communicating in some way that they have a need to feel that their world is somehow safe and predictable. And maybe in that moment it isn't that safe or predictable. Like maybe you are about to go to the hospital for an appointment, and that can be a scary or anxiety-provoking thing. And so then you're faced with like, what can I do to help make the world more safe and predictable in this moment? you try and if you can't, then it's about even just acknowledging that feeling, right? Like you're really nervous about going to the hospital, and so that's, what kind of interventions can you use? Create routines with cues, avoid introducing uncertainty, just finding ways to distract someone. Avoid introducing uncertainty, like, do you tell the person like 2 weeks in advance that they have an appointment coming up, or do you tell them the morning of, what do you want to spend 2 weeks worrying about the appointment? Like it's a very individual thing, right? So some people clearly would want to know. There's this whole thing about therapeutic lies. Do people ever use therapeutic lies? Have you? Yeah. It's controversial, and again, it's one of the things that not everyone says. I think it's about choosing the place and the time and making sure that the lie is small. And so an example would be where's my husband? When is he coming home from work? And he had passed away 10 years earlier. And so what do you do in that moment? Do you orient them to the fact that their husband passed away 10 years ago? Do you say he'll be home from work in about an hour? And so again, there's no right or wrong way, and a lot depends on the person, right? So if this is a person that actually does really most of the time remember that her husband has passed away, and you've just told them this lie that he'll be back in an hour, and like in an hour from now she'll remember that he's actually passed away, and you lied to her, then that ruptures trust, right? But if you have someone who genuinely never remembers that her husband has passed away, and you've reoriented her to the fact that he's passed away, you've tried it a few times, and it just causes her loads of distress every time that you do it. She just relives the mourning and the grief. And at that point, then maybe it does make sense that in that moment she's asking when her husband is coming home, and maybe what she's saying is, I'm feeling a little lonely, and so you do what you need to do to distract her away from that idea. You provide her a little bit of what she needs, and then it might be a very small therapeutic lie in that setting. So any questions about some of that? Yeah.
What if you find yourself saying all the time, it's okay, it's okay, it's okay.
Yeah.
But it's not okay. You might have a perfect storm of health problems, psychiatric problems, the whole thing.
Yeah. So you're talking about how do you reassure people? So I'll repeat the question, yeah. The question is, what if you find yourself saying all the time, it's okay, it's okay, it's okay, even when, really it's not that okay, right? There are things going on. The person has dementia and they're struggling, and the environment, or they're unwell, or there's something, and so you're trying to reassure them. How do you reassure someone without feeling like you're, like a broken record, and maybe it's not that reassuring for them to hear that it's okay, and yeah. There's one of the resources that I think you have. I've given you a link for this app and some of the resources from the Reitman Center. And so one of the things that they teach is how to validate, and so sometimes maybe saying it's okay doesn't work because the person is in that moment is not really feeling heard, right? Like you're kind of like saying, let's move past this, and so what they talk about is finding ways to validate rather than just sort of blankly reassure. So it's been a really hard day. I hope tomorrow is going to be better. I think we've got some things to look forward to. I think we'll be okay tomorrow. But today's been really hard, So that's in a way it's a little bit more validating than just being saying it's okay, don't worry anymore. So acknowledging them a little bit where they are sometimes settles someone, right? That they're heard, they're understood, and then you can kind of move on to some of the distraction techniques. So start off with validation, with kind of meeting them where they are in the moment, and then move on to distraction. Like I did with my daughter. I met her where she was, and then I'm like, and maybe now it's time to go to sleep. So yeah. Okay. So this is another example, and I think a common one, and one that we forget, and it's about the kind of daily humiliations that can sometimes, or that can be experienced as humiliations. Of course, we try our best to maintain people's dignity, but in lots of little ways, we compromise it, unintentionally, but it happens. Like, when I tie my daughter's shoelace when she's in front of her classmates, like that's humiliating to her, but we're in a rush, we're going to leave, right? And so if you have someone who throws their food on the floor, And you know, you were reaching over and trying to cut their meat for them, you know, while it was in front of them. And they're saying, stop imposing on me, stop babying me. I don't like this. And they look angry. And so what they're communicating, the need is that they really want their dignity maintained in that moment. And so anyway, so you have, this happens a few times, and then you think, well, how can I avoid this scenario from arising again? Do I need to cut the food before we get to the table? So I'm not reaching over. Do I, you know, change the way the meal times work in some way? Do I serve foods that are easier for them to handle? Et cetera, et cetera. So it's not an easy prescription, right? Because in one case, it might be that the mealtime is too noisy. In another case, it might be that it's too quiet, or, you know, it's so I can't say that one way or another is better. And so that's where it comes down to really trying to think about and understand the behavior in this individual. And so this is a very simple system or approach to understanding behavior. And so, you know, it might not be something that you do if a behavior happens once, you know, because, you know, but if there's a clear pattern where someone, you know, something is happening and it's happening often enough and it's causing some distress or some, you know, disturbance in terms of your ability to provide your caregiver role, it's worth to sit down and think about in a systematic way. And so the first thing is to think about the trigger. And of course, that really is sometimes not obvious, but thinking about the situation. And it's thinking about what was happening around the person at the time. So the trigger was the meal time. Was it like it was a moment you reached over to cut the meat? And also what you were feeling at that time, right? Because you have to think the trigger might not be in the person, it might have been in you. Like, so with my daughter, the trigger was that I was distracted and thinking about the presentation today, and I wasn't really in the moment with her and paying attention to her like she wanted. So the trigger can be from lots of different sources. And then it's thinking about really what the behavior was. So sometimes I ask my nurses to complete these, and I get agitation. And I'm like, what does that mean? You know, thinking really specifically, they threw their food, they yelled at me, they called me this, they stomped away. So what is it that actually happened in that moment? And then how did you react? Because that's the other thing, is like I said earlier, we find all kinds of ways of reinforcing behavior. And so if I was doing this for my daughter, I would put my reaction was that I lost my temper with her. And that's important to know, right? Because it's, so how is it that we get caught up in these scenarios? And then it helps us to problem solve about how to not get caught up in these. And the other reason I'm presenting you guys this kind of simple way of thinking about it, some people call it also ABC charting, but I don't like ABC. It's simpler to understand it as trigger, behavior, reaction, is that this kind of information is really helpful for your doctor. So if you're going to see your psychiatrist or someone and there's been a change in the person's behavior and sometimes it's really, we want to get to the bottom of it too. And so having information like this is, so if someone just comes, well, he's really agitated. Tell me more. So collecting this kind of information can help in that context too. And it helps to think about finding ways to address these behaviors. The triggers are lots of different triggers, could be all kinds of different things. So if I'm hearing about someone there's been a real change, like they were doing okay in the past 2 days, they're suddenly more agitated, more upset, shouting or, not letting the caregivers help. Like, okay, what has changed, right? Something's changed. And so you think about medical problems, pain, changes in the social environment, someone's left, someone, a new caregiver, they've had a few very bad nights sleep, and so that's thrown them off. So all of these are examples of, does anyone have anything to add to this list? I tried to be exhaustive as possible, but any other things that you guys have come across that may serve as triggers? Sorry? Loneliness, yeah. Like a few, you've had some really boring days, yeah. So lack of exercise, yeah. So yeah, absolutely. Some really inactive days can certainly leave people feeling not great.
I find that when I'm in the emergency department, certain people that the patients do see, like family members, is seen as a trigger for them, and they have their behaviors kind of.
Yeah, I mean that might be. There could be a few reasons why people get more upset when they see their family. And in part, that could be like one of these attachment reactions, right? So it's like they're calm because they're like, whoa, where is this? You know, what's going on? They're keeping quiet because they don't want to cause any trouble because they're really scared and they don't know where they are. And then their caregiver arrives and then, oh my God, you know, like, yeah, get me out of here. You know, all of the sort of, you know, where have you been? Why aren't you, you know, and anger and all of those emotions can come out in that kind of like attachment. Or it could be that there's something more complicated going on in that relationship that, you know, yeah. Any other thoughts about triggers and, okay. So this is, I mean, there are all kinds of, you've got a few sort of photocopies of different kinds of advice and, but so the essence of these kinds of things are that the idea that we have to try to sort of stay in the moment and to, you know, because it's I don't know if you guys do a little bit of mindfulness. That's a wonderful thing for caregivers to do because it is so easy in a moment of crisis to be like, oh my God, this is happening again. This is such a crisis. This is, you know, you go into your mind, right? You start to think about this. There's no way I can keep doing this. There's no. I can't believe that he's acting like this again. You know, and you've lost the connection with the moment, right? Because it's set you off in a way in your own mind, and so it's about really trying to stay in the moment and being what's happening now, staying calm, staying alert, thinking about what's happening. Doing what you can to reassure or listen and use distraction, and trying your best to not you know, lose your temper yourself and finding the support that you need. This is a very simple kind of list, but I think there's more detailed sort of descriptions in your handouts about different ways of approaching a sort of situation like that. I said I would talk about behaviors of risk, and I do in this section. So I'll come to that in a second. It's 11. Okay. I haven't taken a lot of questions from you guys, but I'll just touch on medications, and then I'll take more questions about those if the question, because it's hard to know exactly what to talk about in this scenario. So where do medications come into the equation? And so the way the first of all, it's like a big decision, right? Because we don't like the thought of giving people medications unless they're necessary. And so it's about weighing the behavior in the context of risks. Because the risks, there are risks to medications. There is no medication out there that does not come with risks and side effects. So we have to be aware of that. And the way we think about, the risks of using the medication, the risks of medications outweigh the benefits when we think that the expected benefits are going to actually be quite minimal. So where, the medication is for a behavior that doesn't really respond to medication, or the behavior is actually mostly manageable, and in which case we're really going to go to a medication, and where the side effects of the medications are very distressing and uncomfortable and problematic, and so it's about achieving a kind of balance. So the cases where I really think that medications are clearly indicated, right, are where there is really clear targeted violence or threats of violence, right? Where you are fearing for your safety, where someone is, and this is not just resistance to care, I'm talking about aggression. So remember, I made that distinction earlier. So I'm talking about aggression. And that the behaviors are in the context of psychosis. So because psychosis is a treatment, and we have a treatment for that. And psychosis can affect people's judgment and their thinking, right? If they really think that you are trying to kill them, they are going to be angry and defensive, and we have to address that. We can't leave that untreated, okay? So these are my red flags and the cases where I really strongly recommend to families, even people who I know are very reluctant to use medications, that we should think about using medications. So these are the behaviors in general that we think about often amenable to treatment with medications. Again, so this is not 100%. So some behaviors are really hard to treat with medications, but if someone comes with one of these behaviors, we might discuss the use of medications as an option, right? So these are the aggressive behaviors typically. And then a lot of the affective symptoms, like the depression and the anxiety, those are a little bit more amenable to treatment. And then the sexually disinhibited, those medications are really hard on people, but if someone is truly very sexually disinhibited and putting people at risk from their sexual behaviors, then we face that difficult decision about treating. These are behaviors that don't typically respond well to medications. And in some ways, the medications can sometimes aggravate these behaviors. So if you have someone who's very restless and wandering, and then you put them on an antipsychotic medication, some antipsychotics can make restlessness worse. Or you affect their mobility, so they're restless and wandering, and now they can't walk so great, and so they're falling a lot, right? So we face this dilemma, like, do we want to try to address this behavior with a medication that might, in some ways, make the outcome worse for them? Yeah, if they're undressing, eating things they shouldn't eat. It's really distressing to caregivers, really disgusting. People find it upsetting, but we don't have a pill for that, really, So the guidelines right now is that we should only use medications in the context of dementia when we've tried other interventions and there hasn't been a response. So like what we call non-pharmacological interventions. So we've tried to put in different strategies and approaches, and then we would go to medications. And so really very, very simple. If there's evidence of depression or very severe anxiety, we use antidepressants. And if there's evidence of aggression or psychosis, then we use antipsychotics. And so these are the 3 antipsychotics that are at the moment recommended. So the way, of course, in every individual is very different. And so I'm going to get through this a little quickly, but the idea is that like this medication works for X, but it doesn't work for Y, and vice versa. It's really hard to say right away if someone is going to help or not. And so if I'm going to start a trial of a medication, if my family member is going to go on a medication, I'm going to make sure that I'm monitoring whether it's helping or not. And the way to do that is to assess the behavior before they start the medication. Try to find a way to quantify it. And we have all kinds of scales and sort of things. Put a number to how severe the behavior is. And then do the scale again once they come back. I really, really emphasize this because it's sometimes, because time passes, it's sometimes hard to know, has the medication helped or not? And sometimes I ask family members, did it help? And they don't know. And then we have a real dilemma, right? Because now we have them on medication and we don't know if it's helped or not. So really important to observe, to measure, and monitor for whether the medication has helped. So I kind of touched on that already. And this idea that we have to kind of observe and think about what are the symptoms underlying these behaviors. Okay. So the big side effects that we worry about. So these are the side effects of any kind of medication that acts on the brain, basically. So it's mostly antipsychotics. So antipsychotics will cause people to develop Parkinson's-like symptoms. It's a known side effect. They can cause these abnormal movements of the face and the body called tardive dyskinesia. It's not very common, but it's common enough. It's about 5% of people who end up on these medications. They can cause this restlessness. It's called akathisia. So it's a medication-induced restlessness, and it can cause falls. It can worsen. So definitely, there's no question that antipsychotics make people a little bit more confused. So there's going to be a little bit of a change in their cognition on an antipsychotic. And there are side effects with antidepressants, although they're less severe, they're generally well tolerated, but they certainly also increase the risk of falls. So I kind of talked to you about some of the movement disorders that we see with antipsychotics. So you see there's this real balancing act. Nobody wants to induce a movement disorder in their person that they're caring for, but if they've been aggressive, then you're faced with that. The other big risk is a risk of death. And so that's the may have heard about the black box warning. So there's a warning on all of these antipsychotic medications that in people with dementia, there's about a risk of death that's about 1 in 100. So 100 people who were given the antipsychotic and 100 people were given placebo, people with dementia, there was 1 more death in the group that got the antipsychotic. And I totally believe that these medications, they're powerful medications. So But they work. And so I want to give that message as well, that in people who are aggressive or psychotic, these medications offer them a relief from that distress. And so the other opposite side of the number of people who are number needed to harm, which is what I said is 100. 100 people, one person is harmed. The number needed to treat is 10. So if you give the medication to 10 people, one person will really clearly benefit. I think it's a little higher than that. In my experience, maybe a third of people who end up on an antipsychotic clearly benefit in a real way with that medication. Yeah. Mm-hmm.
The SSRIs.
Yeah.
I don't understand the word.
Hyponatremia. Yeah, so in older adults who go on the antidepressant class called the SSRIs, they can sometimes get a lowering of the sodium in their system. So they would go and get a blood work and their serum salt the number would be low. And if it gets very low, it can cause confusion and delirium. And so again, it's not a super common side effect, but if someone has just started on an antidepressant and like 5 days later, they're really confused, they have to get to the hospital and get checked out because that's a common side effect. It's a possible side effect, yeah.
Okay, and cardiac side effects?
So of the antipsychotics, they can, or of the antidepressants, also not very common. There's the citalopram and escitalopram are two commonly used antidepressants, and they can sometimes, very rarely, contribute to heart arrhythmia, like a serious one. But it's not very common, and it's usually at higher doses, at doses we don't give adults, so older adults. So, yeah.
This is very personal.
Yeah.
My husband was given a memory-enhancing drug.
Right.
And it was at 5 milligrams.
Mm-hmm.
And the geriatric doctor who was going to boost it up to 10 said, oh, that I didn't do that because it lowered blood pressure. It's already low enough.
Yeah.
I'm sorry, I don't know the name. I don't have the name of the drug with
Yeah.
me. No. How risky is this tendency toward low blood pressure?
So you're talking about the cholinesterase inhibitors, which are the memory pills that we use. Yeah. Blood pressure, not as common. I know it can really lower heart rate in some people. Yeah, so those medications are tricky because they can be hard to titrate. People sometimes don't tolerate them, especially at the higher doses, for a lot of different reasons, not just cardiac reasons and blood pressure reasons. But
So there is no real benefit to going to 10 if, in fact, there is some reaction already.
yeah, that's a dilemma that we often face: is if they are not tolerating the higher dose, whether they should stay on it at the lower dose, or whether maybe they should try a different medication in the same class. And that sometimes is done so that maybe that particular drug they have a reaction to, but there's 2 other drugs in the same class. And so sometimes people will switch because it's one of those medications that you do get, it seems to be that you get more benefit at the higher dose. Dr. Tartaglia was here a second ago, and she would be the one to give the best advice about those medications. And typically we think that the higher dose is better than the... Well, I was just answering a question about going to the top dose on cholinesterase inhibitors and whether it's worth getting there. And I was saying that it generally is. Yeah, yeah.
For some other diseases like Lewy body, people that have been trialed in higher doses, it's accepted in the States here, it hasn't actually formed.
Yeah.
Those people can see quite a bit of benefit. So, the dose that was in the trial was 10 milligrams. So that's what we have the evidence for, and so we try to go with our evidence.
But there's a benefit of being at 10 over 5 in general, if people can tolerate it. So that's the difference. It's about, like, if they can get there, you try to get them there. But if they can't, then either you keep them on the 5 if you think it's helped, or if you think you could try a different of the cholinesterase inhibitors because they all have different side effects. So. Sure, we could talk about that. Okay. And I haven't talked about those class of medication. Oh, I've got another question. Yeah.
So do we keep managing the other medical conditions like high blood pressure if they have atrial failure or diabetes? Would this affect would this make a difference, especially if they are on antipsychotic or?
So antipsychotics can impact those. So we're talking about other medical conditions that people might have and how to continue to, so yes, I mean, if someone's having high sugars and low sugars, like that's going to throw them off. That can contribute to behavioral changes. So you have to keep managing those other conditions. And some antipsychotics can actually cause people's diabetes to get a little bit wonky, and so you have to stay on top of those things. Yeah. Let's go jump ahead. Okay, my last slide. So I always give these talks, and I always say at the end, like, it's way easier said than done. Like, I could give these talks all the time, and then, and then I go back to see families and work on my inpatient unit, and it's always more complicated in reality than when we talk. But I hope that this gives a little bit of a perspective about how we see behaviors, and how caregivers, and hopefully empowers you to talk about behaviors with your physicians, and to think about how to give you some skills in observing behaviors in the moment, finding ways to make use of resources and accept help when it's needed. Yeah, hi. Does dementia lead to death? Is that what your question is? Yeah, so dementia can be a chronic, life-limiting illness. It can be, but it's kind of complicated, obviously, because most people who get dementia are older and they have a lot of other medical conditions. So most people who have dementia don't die of their dementia, but some people do. Prevent death in dementia. We don't have any medications that slow the progression of the actual disease of dementia. Really, what keeps people alive is the quality of the care that they receive, right? Because it's the things that get people with dementia are things like falls and injuries that arise from falls, and pneumonias they get from, aspirating food, and pressure sores from immobility, those are the things that usually get people, yeah. So that's a bigger. So I might. Can I just come back? We'll come back to that. I think that might be a question that's better directed to Dr. Tartaglia, who's still here. She's asking about genetic risk. Why don't we save that for later? Because I think it's a little bit off topic. So here's some of the resources I promised you guys. So this is a really cool app that kind of takes you through learning an approach to how to talk, and it's very clear and intuitive, and it's like a skills building kind of app. It's not an advice, although you can use it like an advice seeking, because it has common scenarios, and you go in and you look at those common scenarios, and there's this link, a YouTube link for a video about communication. So again, about how do you manage that communication in that moment. There's so much education resources, and these are just a few that I thought were good. And then there's actually an online stress management program for caregivers. I really hate that picture. It's a really mean-looking woman. So it has a whole sort of a module about how to manage, how to cope when you've got someone with behaviors. So, okay. Oh yeah, my last thing is, so the Ontario government just paying for these new dementia care navigators to be accessed through First Link, and so that's about taking advantage of resources. So the government is throwing money at this right now, and so connect yourself up to First Link, get yourself a dementia care navigator, get the resources that you need, because they say they're going to pay for it. So, oh sure, yeah. I mean, in terms of the actual altering the actual neurodegeneration. So we have these medications, the memory pills that we use, that seem to maintain people's function a little bit longer. But so it looks like we're slowing the decline, but we're not actually slowing the disease. The disease is still happening. Yeah.
I've seen some of the government reports, and they rate different institutions. They talk about the use of psychotropic drugs, and a lot of the prescribing is done without a diagnosis.
Yeah.
And that's how the government tracks it. And so, is it important to first have a diagnosis? And are these drugs being prescribed for the patient, or are they being done for the benefit of staff?
This is a complicated question, but I'll try my best to answer it. So what you're referring to is the antipsychotic use in nursing homes is considered a quality indicator. So they look to see, it's one of the ways they evaluate the quality of the nursing home. And it's kind of controversial and problematic because, of course, you could have very good quality care and have people who need antipsychotics in your setting. And you know, some nursing homes, you know, they start refusing people who are on antipsychotics because they don't want it to affect their quality, and it creates all kinds of other issues. But yeah, so it's an indicator, and you're right. So the use of antipsychotics for people with delusions and psychosis is an approved, you know, that's approved. But if someone doesn't have psychosis and they're just using the antipsychotic to manage aggression without psychosis, that's not considered a quality. It's reflected in the quality indicator. So I work in nursing homes, and I would say that it varies a lot in terms of how well or not well these medications are used. They're certainly very aware of the issue, and they've become increasingly attentive to using them appropriately. So I'm not of the group that thinks that you should never use these medications. And there are people out there who advocate for that because they're really important in managing risk. So sometimes it's about the person because they are so upset, so agitated, so distressed that they're putting themselves at risk. And sometimes it's about protecting the staff because you have someone who's very aggressive that they are injuring staff members. And sometimes it's about protecting other residents. So certainly if you have a loved one in a long-term care facility and there's a really aggressive guy in the room next door, you would want to know that his aggression was being treated or managed in some way to protect your family member, right? So yeah, it's balancing a lot of those different sort of, you know, stakeholders. All these different people have different reasons for being on the medications or not being on the medications. What I say to family members is make sure you have a really clear discussion with them about why they want to start the medication, right? And so you can use a little bit of, if they're not really being aggressive, if they want to start it because they're wandering, right? That's not a good indication to start an antipsychotic. If they want to give it to them because they're verbally agitated, like they're shouting out help, 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 that's also not a great indication for an antipsychotic. It has to be clearly like some kind of risk, I think. And sometimes, yeah, so that's how the advice I give to families, to have a clear goal for the treatment. So like we're going to use this medication and the aim is for them to, you know, and then after they've been on it for a while, you know, make sure you have that visit where you reassess, like, how have we achieved our goal? Is this medication working? What are we going to do next? And if they're on a medication and it's not helping, then it's very fair to ask that the medication be switched or changed, right? That it shouldn't just be someone goes on an antipsychotic and that's it, they're done. You know, you don't evaluate anymore. You know, you have to continue to evaluate whether they need it and whether they're benefiting from it. But yeah, this is complicated. Yeah.
On one of your slides, it might have been your last one, you had this statement of accommodating behaviors in loved one can mean loss for caregiver.
Yeah. Well, so the question is, in my earlier slide, I said that accommodating behaviors can mean loss for caregivers. Because to some extent, like they're not the person that they were, right? And so he would never have spit on the floor, and so I want to correct him, right? Or he would never have yelled at me. You know, that's not something that he would do, and so it feels really wrong and off. And so often I get people say, I can't believe it. He raised his voice, and I'm really sorry that he raised his voice. Let's see what we can do, but we're going to have to accommodate that maybe a little bit, you know, maybe he's going to get frustrated and he might do things that are out of character for him. And then, so that's a loss. That's, you know, that they're not who they were. And how do we move forward? Yeah.
I'm not a primary caregiver, but I go back home and visit sometimes. And I'm wondering if there's anything that you see sort of alternate relationship building strategies for people who come in. I'm an artist, and I know sometimes music
Yeah.
can be helpful, or it's something you've noticed.
So you're talking about some different kinds of non-pharmacological approaches, and I didn't touch on that in this presentation because I'm a psychiatrist, and this is the perspective. But I'm a firm believer. And so when I was saying earlier that you have to try other interventions first before we go to medications, that's kind of what I'm talking about, is that there are lots of ways to engage people to address some of those needs that we talked about, right? So if they are feeling understimulated, if they don't have a sense of purpose in their day-to-day life, how do we provide that to them in some way? And so there are all kinds of recreation approaches that are, you know, different kinds of reminiscence therapies, music and art, you know, the programming, so different kinds, you know, the day programs that a lot of older adults go to are, you know, so sometimes family members are reluctant. They're like, why would they want to go there? Because it gives them these things that they can't always get from you. You know, you give them as much as you can, but they need the stimulation and the social interaction and the time away from you and the, you know, the physical activity of those kinds of programs. And so, yeah, so those are all different kinds of examples. And so there's a lot of you know, we don't have, it's one of those things that we're not very good at studying. They're really hard to study. And because I think the response to them is so variable, like I might like a massage, but you might not like a massage, you know. So it's really hard. It needs to be so individualized. But those are all kinds of different non-pharmacological. Do we have a good resource for people about different kinds of non-pharmacological approaches? I didn't touch on it today. So if you want, I can try to find a resource and find a way to distribute it. So. On the Alzheimer's Society website, they have some, yeah, exercise activities. Oh, you know what I've really, what's taken off on our inpatient unit recently is the iPad, which is, but the kinds of games that people like are the casino game, like slots, you know, they sit and will play slots for hours. And I mean, there's no money coming out, you know, but the satisfaction of, you know, hitting the 3 cherries is, and there's a bubble popping game that they seem to love, you know, and that's like, you know, like you touch the bubble and it pops. It's really great, like cause and effect. You have an effect on the world around you in a way that if you're feeling really powerless, you don't often have anymore. So, yeah. Yeah, hi.
Hi, do you mind flipping it back to the, or forward to the app slide?
Oh yeah, the app here. Oh. Okay. I think there's a photocopy of this in your, yeah, in your little package, but yeah.
So all of the resources that you talked about are actually in the folder.
Yeah. So I don't know. I think I've lost track of time, but I think this is maybe a good time to stop. But I'm going to hang around for a bit for any other questions that people have, and hopefully you have a chance to talk amongst yourselves. Then thank you all very much for coming. And yeah.
Just a reminder that you guys have the post surveys too in your folders. You can leave them on the table. If they're already completed, we'll come by and pick those up. You're more than welcome to help yourself to the coffee and whatever is left of the refreshments. And thank you again to Dr. Aya Boney.
Hello everyone, my name is Iman. I'm from Medic Alert Foundation in Canada. I have a display outside for the Medic Alert bracelet. We have partnership with the Alzheimer's Society of Canada, and I have our new GPS as well. Not only this, today when you sign up, we are offering 50% off the service plan. So instead of you getting the ID, no registration, no shipping, no tax, you should pay $60 for the whole year. Today it's $30 only, and you get the bracelet for your loved one. Thank you.